Let's go ahead and get started. Just one piece of business that may interest people. For those who are fellows in the Academy, you can actually register for the meeting already.
Yeah.
It seems to me awfully early, so I don't know if you got an announcement about that, but if you want to take advantage, I went ahead and registered and actually booked a hotel. The hotels that the Quad AI gives, they're all pretty pricey. If you look around on TripAdvisor, it looks to me like you can find better places in walking distance at half the price.
Yeah.
But anyway, just to be aware, if you can remember your sign-on information, you can sign on and register for the meeting in advance. Actually, we have supposed to have 3 presentations today. Jim Stout, who's a friend and a colleague and a professor of pediatrics, asked me if he could actually come and present what his group is doing in pediatric pulmonology, except he's not here. I have his handout, and we've got the presentation. I'll have to figure out as soon as I walk away from the lecture and ask Joan to call him and see what's going on. Well, here he is.
Yeah, he was wandering around the building.
All right.
I found him!
So we'll switch gears here for a minute and change what the presentations are going to be. Over here in just a second. So this was supposed to be a journal session, and we have journals as well. Paul McBride and Drew Ayars are also going to present. So Jim is going to take half or slightly less than half of the session to tell us what his group here in pediatric pulmonology has been doing about remote teaching and education of spirometry. Jim's a professor of pediatrics at the University of Washington. Many of us know him also at Odessa Brown Clinic. So glad you got here just in the nick of time. Come on up here.
Who knew street parking would be an issue at 7 a.m., right?
Yeah.
Thanks, Lynn. Well, I'm delighted to be here. I'm, also amazed and delighted to see so many people up and at a talk at 7 a.m. Pediatricians are not this stuff, I can tell you. I'm going to take a few minutes and tell you about our program with a specific purpose, which is to see if it might have any interest in a general allergy practice. That's really why I'm here. That's not where we started, but I'm hoping it makes sense for me to be here. I have no disclosures or conflicts in my work life. Session objectives. I want to briefly go over how we got started, sort of tell you how we got to this point, describe the program to you, talk about our results for just a minute, and basically consider these resources, like I just mentioned, from the perspective of your practice, those of you in practice. This is a good moment for me to call out my dear old friend Gail Shapiro. In 1994, I decided to start an asthma program at Odessa Brown Children's Clinic and shadowed her a number of times. And in addition to lots of great clinical knowledge, I came back to my practice at Odessa Brown with 2 procedures not generally done in primary care, one being spirometry, the other being scratch testing for airborne allergens. Both of which Gail supported us in getting started there. The reason we got this started, though, was really for the following clinical reasons. It was just my impression over time that patients often didn't know when they were obstructed. I realize I'm not telling you anything that's new information, and that significant obstruction can be present even when the chest is clear on physical exam. This is actually kind of a surprising and almost heretical statement to a general pediatrician or family doc sometimes, just because they still need to be convinced that there's a clinical role for spirometry in asthma care. Clinical symptoms alone will underestimate severity about a third of the time. I published a paper along with several great colleagues, including Gail, in 2006, basically showing that many kids were up-classified when their lung function was considered. 1 out of 3 kids were up-classified once their lung function was considered. And as you all know, peak flow testing alone is very variable and not a very sensitive measure of obstruction. and no longer recommended for diagnosis of asthma as of the 2002 guideline. In primary care, there are some pretty obvious barriers, probably the most important being lack of training for support staff and providers, lack of a device, and lack of time, specifically problems with workflow and lack of planned visits. Primary care office is a great place to go if you're acutely sick or if you're coming in for your well child check or your general checkup. Not such a good place if you've got a chronic condition and you need planned care on a routine basis. This is the routine way of doing business, I think, in an allergy office and in many subspecialty offices, but not so in primary care. We're not really configured in most cases to deal with that. So I lead a group at the University of Washington called the Interactive Medical Training Resources Group. We have actually more than 2 titles now, but we're based at UW and basically have membership or involvement from pediatrics, internal medicine, and health services departments. We were founded in 2006 to develop and disseminate and evaluate media-rich interactive online training and feedback for the purposes of improving care. Our marquee program is our spirometry training program. We just concluded a Train the Trainer program where we taught several sites around the country, UCSF, University of Michigan, Mass General Hospital, how to basically deliver our program. And we give them our training materials, and basically they're now training their own communities. We're also training a couple of sites in Adelaide, Australia, which has been really fun just to be able to do this over quite a distance. Our second title, Pediatric Procedural Sedation, is really focused on emergency rooms that sedate kids for a lot of painful stuff and often don't do that well or safely. It occurs to me that maybe a panel of intradermals that might be another time to invoke that training. Our mission is to improve the care delivered in general practice to patients with asthma or COPD. We have 2 tracks of our program, pediatrics, which is where we started. Later this morning, I'll be joining my pediatric pulmonary colleague, Alan Dozier, in delivering our 10th round of this course, which goes for 5 months. I'll show you in a minute. We focus on properly performing and interpreting the spirometric maneuver with a focus on planned care. Now, in primary care, interpretation means the following. It means knowing you've got a good test, knowing if it's normal, knowing if it's obstructed, and knowing if it's anything else. And if it's anything else, it doesn't belong in a primary care office. It needs to be referred on to a specialist, usually a pulmonary or ENT doc, occasionally also an allergist. We emphasize reaching safety net practice populations where the burden of asthma and COPD is greatest. We've gotten a number of sort of grants to provide scholarships to basically low-income serving practices around the country, and that's been a successful way to disseminate the training. We've trained about 300 practices now since 2009 across the country, about evenly distributed between pediatrics and family practice. And we are able to make our training available to geographically isolated practices. These tend to be the folks that are most excited to have the opportunity to get some specialized learning, which is otherwise really hard to get to in those settings. We published a paper earlier this year in Academic Pediatrics showing that our program significantly increases the proportion of acceptable spirometry tests and also significantly increases appropriate asthma severity labeling, which then leads to appropriate treatment. So the program works. We've got good documentation of that now. The focus for us really is on coaching the maneuver, is on administering the maneuver. And although we also spend a fair amount of time on interpretation, I frankly don't think that's the component of this program that would be of most interest to you. I'm more interested in just your thoughts about using it to train support staff. Spirometry Fundamentals is an online multimedia tutorial that we produced in 2006. I think it first rolled out. Some of you may be familiar with this. Gail Shapiro was very involved in helping us develop this and was a wonderful content expert along with Greg Redding at Children's. Shortly after we produced this and began disseminating it, we did a trial of it and put it in 40 practices, 40 primary care practices around the country, and looked at the quality of tests by uploading them and then grading them according to ATS criteria, blinded to allocation, of course. What we found kind of surprised and disappointed us, which is that it didn't change a thing in terms of the quality of the test. People did more tests, but it was not, and I should have brought a clip to show you, but this is a still of this multimedia tool. What people told us back is this is a wonderful tool, we like it a lot, but it's not enough. We also need to have a way to do case-based practice in order to feel confident in putting the procedure into practice. And we need feedback on our on how to do the test and whether we're doing it right or not. I think one thing available in your office is someone with experience in doing this procedure. In primary care, that person is usually missing. And even if you have such a person, if he or she is out on a day, there often is not a second person that knows how to do this. You know, I was struck when I shadowed Gail that this was treated as a vital sign for people coming into the office. That seems entirely appropriate to me if you've got a respiratory issue. In primary care, that's done less than half the time, and when it is done, it's typically not done well. Also, a little under half the time. So we now follow that tutorial, and that's sort of considered the primer for those taking the course. It's where the nomenclature, this is a volume time curve, this is a flow volume curve, this is how you coach your patient, that sort of thing. And then we sort of take it to the next step, which are the learning labs. I'm only going to talk just for a second about the coach learning labs, and there are two of them. They're both 90 minutes in length. The first is on performing a good test using the ATS rules. The second is on recognizing and fixing common errors, sort of the blooper call. We actually did that just last week. Just the basic things like recognizing a cough or a short effort or not enough efforts, that sort of thing. And these are very effective, I think, in sort of a case-based format. We deliver them two ways. One is live. It's a live webinar, and people can join that. A lot of people prefer a sort of a virtual classroom format like we're doing this morning, if anyone's sort of watching remotely. And then the other, in addition to providing it that way, we, this year for the first time, have introduced a system called Canvas, which is a learning management system. It's enabled us to take all of our recorded webinars and put them on this system, which enables interactivity so that you can take quiz questions, have your attendance taken, get feedback on right or wrong answers, that sort of thing. It's a very robust system. It's open source software built on the Ruby on Rails platform, if anyone is familiar with software. And so we've done that. Last spring we started producing these on Canvas, and a lot of folks are in this season of the training. We deliver the course twice a year. Are using the learning management system, and the cases go like this. I mean, we'll put up there's a polling feature, which I'm sure those of you that have used WebEx are familiar with, and we'll put up a test and basically something equivocal like this with a little cough after the first second, and see if people would accept it or not is clinically useful. And then we stop and discuss the case if there are questions. This also is just a quick look at the interface for us, and this is sort of leading up to the third component of the training, which is feedback. And what we've done is interface right now with one device, the NDD Easy One machine, and once our software is downloaded, it uploads the test to us, which is stripped of identifiers. So there's no name or date of birth, just age and years and gender and the other demographics that go into the normative predictor set. And then we use that to basically compile feedback and give it back to the coaches at a particular practice. So this is the third component. This is really the innovative thing we're doing, which is this remote overreading and feedback to primary care offices. We found that these are crucial to improving the success. It's, learning spirometry for the first time is much like learning to play a musical instrument or drive a car. You first need to learn the basic rules, and then you need to practice and get some feedback. And these activities for us represent about 3/4 of the work we put into delivering the course. We overread every single test, drop a comment in the comment box, And then practices, in addition to getting a summary report at the end of the month, can go into their data set and look at their individual tests for individual comments. Because again, they're de-identified. We don't have a patient name on them. The feedback reporting system also enables us to roll up run charts. This is, I don't think there's a pointer up here, but I think you can get the idea here. This is way back in 2009.
On the screen, on the computer.
Mouse. Oh, let's check that out. Okay, so here's the x-axis in months. The course runs, we have a baseline and then basically 4 intervention months. And this is the total number of tests here. So this is the quantity, and you can see the quality over here. And the other thing we've done is stratified according to age. When we first started doing this, we thought that younger kids would have a harder time with this test, kids younger than 8. And as it turns out, they do as well or better, at least in a pediatric population, as the older kids. The smoking gun here are the young adolescents, the kids that just get embarrassed to do a forced expiratory maneuver, and they require some coaching and coercion a little bit different than you would use for younger kids. We encourage folks to start this test at about age 5. At least in primary care, we discourage people from doing the inspiratory flow loop for 2 reasons. One, it's a little trickier to do than the expiratory maneuver. 2, if you find anything unusual, it doesn't belong in a primary care office anyway. It probably belongs in an ENT's office. So we really focus on the expiratory maneuver. This is the timeline of the course, and you can see this is a very busy slide, but a lot of it is just sort of the pre-work, getting folks to complete the license agreement, they get their welcome packet. Collecting baseline data is a key piece of this. We need to make sure their spirometer is configured appropriately. And then they review the spirometry fundamentals tutorial online. They attend the learning labs, again, either in person or self-paced. And then they upload data to us for a total of 5 months. And they get 4 feedback reports. The first summarizing the first 2 baseline months, which is really just making sure that they've got their device together and working. It's really kind of a bimodal distribution for us folks that have been doing the test in primary care for a number of years and just never got formally trained and are looking for some way to do that. The other folks are brand new to this, and they're just taking the spirometer out of the box, and so everything is new in that setting. We have a bank of about 12 or 15 loaner devices, NDD devices. It's much easier for us and for the practice to use that instead of another device, which I'll sort of walk you through in a second. All team members view spirometry fundamentals. They attend the learning labs. And then we encourage folks to meet at least monthly to review these tests, review the successes and challenges from the test, decide how to make their next incremental quality improvement. And we encourage folks to do this in sort of an incremental way, using quality improvement methods of the Plan, Do, Study, Act cycle and sort of other elements of the model for improvement. In order to send us tests from a device other than the NDD, and I suspect that this would be the case in most allergy offices, we have you photocopy the test, redact name and date of birth, and send it to us in mailers that we provide. We ask you to do that twice monthly, and we basically scan those data into the feedback reporting system, and they join the data set along with the NDD test. We've done this, I would say, over the years. About 2/3 of our practices have used NDD devices, and the balance have used other devices. And it works perfectly well. It's just tedious and potentially error-prone to do the paper method. The NDD method, like I mentioned earlier, starts with the device, which imports the data into EasyWare and then to us, stripped of PHI, and we do the overreading and feedback using that interface. I didn't bring slides about this, but something we're working on now. I'm working with Margaret Rosenfeld at Children's and a computer scientist named Shwetak Patel at the CSE department at University of Washington, and he's working on a cell phone spirometer, which amazingly, you hold it out in front of you and blow towards it. And have you seen it? And
No.
I was just curious.
That sounds like what's necessary
Yeah, well, it is in order to get around the paper method for us. And our agenda on that is training. Shweta and Margaret's agenda is to develop something that can be used as a home monitoring tool. So,
Do you need a device to plug into the phone?
nope, it's just you go right into the phone. It's fascinating. It uses the microphone and repurposes sound waves, which strips out all the vocal noise and just takes sort of tracheal reverberations and turns it into a Fovine curve that matches within 3% the COCO device. Numbers and everything. It can't do an inspiratory curve. It can only do an expiratory curve. But we'll be using this in the coming years to train with, and we're basically interfacing our feedback reporting system to it, both for home coaching as well as use in a primary care practice that's not using the NDD device. So that will circumvent the need to send us paper and be another way to sort of upload to us automatically. So, which leads to my question for you, and hopefully we have a few minutes left for discussion, but I'm just curious if this would add value to your allergy practice. That's my first question. And sort of right behind that is my wondering how you go about training employees now. I guess my vision of this is that there are experienced people in your offices, and when new employees are hired, that experienced person will do the training and basically feedback in that setting. And it may work perfectly well, or it may be that this is something that could use a little bit of help from us in terms of coaching your folks, as well as ongoing quality control in your offices.
Steve just walked in, even though he missed the presentation. We'll fill him in very quickly.
Sorry. In conclusion.
Yes. Even in a specialty practice like ours, Northwest Asthma and Allergy, where we ought to do spirometry well or perfectly, very often we don't. And every number of months, basically just what you mentioned, we have to set up a tutorial in-house where someone experienced goes to all of our sites and trains new people who came to us as medical assistants, maybe knowing nothing about pulmonary medicine. And this might very well help, not just in primary care, but in specialty offices as well. And Steve can speak to that.
Yeah, so from my point of view, even physicians, specialists can get rusty with examining flow volume loops and making sure that it's reasonable enough to look at the numbers. Because it seems to me, if you want good quality spirometry, you really need to see the dynamic of what's coming out as initial quality control, and then look at the numbers to see if you can believe them at all. And so there are pitfalls, and it's always helpful to have an expert backup, just like overseeing a fellow or something, so you can go in if they're having trouble and watch the effort and make sure you believe that it's valid.
So maybe this would be added value for...
Yeah.
So Jim, it's a 90-minute, is it a 90-minute program that you learn how to do the spirometry, and then there's another 90-minute thing? Is it like you go on the web and you watch like a program?
There's actually 4 90-minute sessions altogether. 2 of them are specifically on coaching. The first on the ATS rules, the second on common errors. And then there's one, where I'm doing one later this morning actually, with Alan Dozier on interpretation. One specifically for pediatrics, the other for family practice, where we address both asthma and COPD issues. And people are basically invited to go to both if they like, and some people do that. So we focus on interpretation as well. I just didn't know if that would be germane to this group to talk about that, but we do. So there's an interpretation webinar, and then the final webinar we call Putting It All Together. And this is where we introduce the idea of a planned visit model in a primary care office around this particular condition or both of these conditions, asthma and COPD. Yeah.
I have a question. In our office, we have each nurse does their own spirometry for the doctor they work with. Mm-hmm. Then we have a pulmonary technician who does it for our pulmonologists, and we can get really good reproducibility with each of the individual nursing staff, and then they send them up to David, who's sort of a scary big guy in the pulmonary lab, and he'll routinely get maybe 5 or 10% better numbers. Even though our staff can get the same value 3 times in a row, he'll still get better. So do you find that with your training that changes?
Well, beyond being able to say this meets acceptability and reproducibility criteria based on ATS guidelines. We haven't gone in and sort of taken a gold standard big scary person to sort of get a maneuverable person to see how they do. So I can't really answer that question, but I think in general it's hard to do a submaximal effort reproducibly. So I think if you're getting reproducible tests, you can pretty much believe what you're looking at. I think that's a reasonable approach.
And then, is there a cost to this program? There is.
Yes.
And what is it?
So what we charge currently is, if you're using the NDD device, it's $900. And if you're using any other spirometer, it's $1,200. It's about $300 more expensive for us to do all the scanning and the paperwork that way. That's for the 4-month program. We haven't really, we don't have a pricing model for ongoing quality control. But we could certainly come up with one if that was a need to be met.
What if you just sold the program part of just teaching the staff how to do it? Watching the 2 webinars.
It's $150 per person, just to have the webinar content, and you have access to that, sort of unlimited access to that for 6 months. The Spirometry Fundamentals tutorial is a 2-year license, so people are encouraged to sort of go back and look at that after the fact.
How do people find you and sign up for that?
Oh, thank you, Len. There we go.
And
So,
do you have grants for people that want to do it that don't have the money?
we did, but
Like allergists?
I'm thinking more
Not
pediatricians.
joking.
yeah, well, we did for a number of years through the NACI program at NIH. It's the National Asthma Control Institute. We had a grant from them to provide scholarships to safety net practices. That program, unfortunately, has run out, so we currently don't have a way to do that.
Can they do a group discount, like if we got like 20 licenses or something?
Well, Steve, it really is a cost-based program. It's not a value-based program. So what we charge is what it costs us to do the overreading and feedback. That's what it costs.
Okay,
And I wish we could say there's sort of a volume discount and we might be able to figure something out. But, the expensive part really is compiling each of the individual tests into a summary report and feeding it back. We have software that organizes error patterns, so that part is done automatically, but we still have to look at the results and think about it for a minute before we give feedback. It looks like it's blocked out, but our website is spirometrytraining.org. My email is jstout, JSTOUT, @uw.edu. So please, if you have any interest in this or would like to discuss it further, I'd be more than happy to talk to you about it.
Do you know if people were seeing on the outside, are they blocked by that image, or
I don't believe so.
so they can see the print? Okay.
That's just for the room.
Well, thank you very much.
My pleasure. Thanks for having me, Lynn.
We've got, we're going to shift gears here for a minute. We've got journals by both Paul McBride and sort of journal mini presentation by Drew. So Drew is standing here. I assume he'll go next.
Paul, do you want to go?
No, because mine tags right into the end of your.
There is a theme this morning. There's a vaccination theme. So, I was doing autism and immunizations, and the reason this came up is a few months ago I was out to eat with another couple, and a very intelligent couple, and it came up that they weren't immunizing their kids, and of course I'm astonished, and when I asked why, they said because this guy in England proved that it causes autism, and of course my reaction was that's bogus, and they asked why that's bogus, and I had no idea. And that really pissed me off that I didn't know. So I thought I'd summarize the data and try and be as objective as possible, but it can be difficult when looking through this. So this all started around 1998 when 2 studies came out. And just to kind of put in perspective how long ago 1998 was, my dad still had hair on the top of his head. So, yeah, it's hard to believe, I know. So this study came out of California, showing a significant increase in autism. They still don't know all the reasons behind that, but they think it's multifactorial. A lot of influx into the system, just being in California where it was, a change in the diagnosis of autism, but underlying there seems to be a significant increase over the years. And of course, what happens when people develop autism around that time? They get immunization, so it's an automatic thing to jump to. And this has got the most press. And before I did this research, I didn't know why, but a majority comes from this guy, Wakefield, in the UK. And the first thing that set this off was a study in The Lancet that happened in 1998. And 2 other studies have been quoted by the folks trying to implicate the MMR, both in 2000 and 2002. The other two are both PCR studies, looking at peripheral blood mononuclear cells, and then the GI tissue of some of these children with autism, showing that there's actually persistent measles viruses. And I'm going to quickly go through all these studies. And again, I'm going to try and be as objective as possible, but it's difficult. So I said this was a study. It's not really a study. It's a case series. So 12 patients consecutively, remember that word, were referred to this guy's practice in England. Most of them had symptoms of autism immediately after the MMR, and they say immediately. And they had an extensive workup, including MRI, EEG. They did LPs on all these kids, and they did colonoscopy to further work this up. And basically they say all these behavioral symptoms in 8 of the 12 children started right after MMR. All the children had intestinal abnormalities, including lymphoid nodular hyperplasia, and remember that, and histology, so patchy chronic inflammation. And basically they come up, we identified associated GI disease and developmental regressions in this previously normal group of children, basically saying, geez, we found this new group of children that's most likely secondary to the MMR vaccination. The second study was in 2000. Again, this is RT-PCR, and this is a relatively new technology at this point. It looked at a control group and then a group with Crohn's, UC, and this autistic enterocolitis. And you can see who's also on this study, Dr. Wakefield. He sent these autistic enterocolitis samples to this lab to be analyzed. When they did the PCR, they found 1 of the 8 in Crohn's, 1 of the 3 in UC, and 3 of the 9 in this autistic enterocolitis had persistent infection by their PCR methods. Another study looked at the actual GI material itself, and they found that the patients with UC and this autistic enterocolitis, they had a big study group, 75 of the 91, or 82%, had persistent measles virus by this PCR, and only 5 of 70 in the controls. So, and this is their closing statement. The data confirm an association between the presence of measles virus and gut pathology in children with developmental disorder. It's a pretty strong statement there. So let's go back and review this. And this is what's come out in the past few years at least. When they actually went back and reviewed these children, they found that 3 didn't have autism at all. They found that 5 had developmental symptoms before the MMR vaccination. So 8 of the 9 have been debunked. This is the best part. They went back and reviewed the records, and they found that most of the children had unremarkable findings on their on the biopsy and the colonoscopy findings. They were changed from unremarkable to non-specific colitis. So these were. He went back and reviewed these, and there were 3 people in the study that went back and reviewed this. And then another thing came out. All these children were recruited by an anti-MMR organization, and he received about $750,000 for his work. In this. But as he notes, I saw an interview with him recently. He donated all of that to charity, so it was all in.
From jail?
Yeah. He's in Texas. 10 of the 13 authors subsequently retracted it, and it was taken out in 2010. So this guy Brian Deere did most of the investigative work on that, and so did the government in the UK. This is great tables. They found that the non-specific colitis, in the Lancet article, they said 11 of 12. When they went back and really looked at it, only 3 of 12 even had colitis. Symptoms after the MMR, 8 of 12 claimed to, but when they went back and looked at the records, maybe 2 had symptoms after their MMR vaccination. And you guys can look at this if you want, but going over every child and saying, how it was misrepresented in the paper. So it subsequently retracted. He has a few more retracted articles that I couldn't track down, so I'm glad they gave him this article, even though I had to read around this red retracted sign to interpret it. So what about these other 2 studies? So these patients have measles virus. So there's been a big effort to try and reproduce this study, and no one else has been able to reproduce either one. This Alfaz has looked at the same kind of studies in patients with MMR, with the autism and controls, and the RT-PCR was negative to all of this, so they haven't been able to reproduce it at all. And this is a great study. If you guys have time, go read this. It's basically looking at the previous 2 RT-PCR studies and basically taking them to task, saying they were totally false. So they reviewed both of their methods, looking at how they did the RT-PCR in both studies. In the first study, at the PBMCs, they did the same exact assay and had 0 positives in either the control or the kids with autism. And the second study, they looked out and found that everyone was positive, both the control and the autism group. And when they actually looked at the curves, they found that these probes were actually latching onto a human protein instead. So I've actually sequenced almost all these different positive samples, and none of them have sequenced measles virus. And both of these people that had published the previous articles really haven't published since, so they haven't come out at all. I'm trying to be fair to both sides, but they haven't published anything refuting the data coming out later. So in the first study, I think they were really well-meaning, but I've done PCR and I know how difficult it is with contamination. That's probably what happened. The second one, they were obviously looking at a sequence that was cross-reacting with the human genome and finding that. So both of them were false. Another study came out, again, looking at tissue. Those previous two were looking at PBMCs. The tissue had the same findings. There was no difference between either group, either the autistic or normal controls in the amount of measles virus RNA. And looking through, going back, Wakefield published in 1993 reporting that there's a monoclonal antibody against measles virus in all of his biopsies in Crohn's. Well, it was later found out that this was actually against a host antigen, so they were reacting to host antigen as well, and this has been proven by multiple labs. And none of these people that found these positive findings have come out at all and had any substance refuting the fact that this was false. So again, this has never been reproduced, either one. The first one was probably because it was contaminated. The second one, again, because they were probably finding the host DNA instead of the viral DNA. So basically all the studies came out for this have been negative. The epidemiologic evidence is even more damning, and I'm not going to go through this in length, but every epidemiologic study has showed zero link. So around this time, when all this data was coming out, Taylor was coming up with data saying there's no increase after the introduction of MMR. And all these news stations were interviewing Wakefield, but not Taylor at that time. So there was just getting, and I'm not blaming the media for all this, but it's a better story to say that this measles virus is causing, and they have parents crying on TV, and it's better TV. Another study out of the British Medical Journal, no increase when MMR was introduced. This is an incredible study. Almost all the children in Denmark, they followed over 500,000 children, representing over 2 million person years, and they found the relative risk was actually higher if you were unvaccinated. It crossed one, but it definitely did not show an increase in the immunized children's. Again, all these studies are basically saying the same thing. This is another interesting one. I forget the reason, but the MMR was taken out of circulation in this small part of Japan. And actually, the rate after the MMR was taken out rose significantly, which I think has nothing to do with it. It just shows that this is being vaccinated. People are. This has nothing to do with it, and the incidence of autism, for whatever reason, is increasing. So really, all these epidemiologic studies have come up with nothing. Another agent implicated is thimerosal. So this used to be in a lot of the childhood vaccinations. It's largely been taken out of all of them. I think it's still in the killed flu vaccination, but none of the routine children's vaccinations. 2 studies have come out basically saying there's no link. This is the same one out of Denmark. Again, looking at huge numbers, and again, there was no increase in the rates in children receiving these thimerosal containing vaccinations. So they've looked at diabetes, they've looked at multiple sclerosis, and there's been no implication of any other chronic disease process that has been caused by autism. So the evidence is out there, right? Well, it's not out there. This was a poll conducted last year around the U.S. So 52% think vaccines don't cause autism. 20% believe it still does. And 30% aren't sure. So almost half think that autism may be caused by vaccinations. And that's sad. That's us not getting the message out. Over this time, because of this research, the MMR rate went from 92 to 80 over about a 10-year period, and at least 3 deaths and multiple outbreaks of measles have occurred because of this. And this hits pretty close to home. I hope you guys can see that, but the highest rate of vaccination opt-out for non-medical reasons is here in Washington State. So this is the biggest problem right here, and we're just not getting the word out. And Interestingly, the lowest rate's out of Mississippi, and you can see there's a big difference. There's a lot of social commentary you can make on that, but this is another article I read, looking into why when we have all these negative studies, why is it so hard to get this message out? And they quote a 60-minute study, and I don't think 60 minutes is being biased here, but when this came out, they interviewed this parent in I think it was Pennsylvania, that was crying on the couch saying, my kid was normal until they had the MMR, and then they interviewed Dr. Wakefield with his findings right afterwards. And they didn't interview this Taylor who was doing great research on the side. So they just got one side because, it's a sexy story. The other thing that makes it difficult is, we're trying to be scientific with this. And it's hard to prove the null hypothesis. So the Institute of Medicine has this statement down here. The committee notes that its conclusion does not exclude the possibility that MMR vaccine could contribute to ASD in a small number of cases. Basically, it's hard to prove the null hypothesis. Could there be a mutation and pigs fly tomorrow? Sure, it's possible, but it's hard to do. So to be respectful to the scientific process and come out with statements that represent the true data can be difficult. So this guy was charged on multiple counts, including dishonesty, irresponsibility, abuse of developmentally challenged children for his study, and has since been barred from practicing in the UK. And he's currently living in Texas now. The guy still has a huge following. He recently did an interview on Fox and Friends where they appropriately attacked him for all this. It was a great interview, actually. But Jenny McCarthy's still out there advocating for him. She wrote the foreword for his book, Callous Disregard. I want to go out and read this, but I don't want to support him by buying it.
She has in the library.
She has an autistic, I know. And I should go to the
Go just get the library.
So his other awards he's won recently, he won one of the worst doctors on Medscape's list. And this is a great one. Time Magazine recently named him one of the great science frauds. So he's picked up a lot of awards along the way. The CDC, again, is very appropriate, but you go to the webpage and this is buried, you have to really look for it, and basically saying all these academies agree that the MMR vaccination is not responsible for the increases in the number of children with autism. The WHO recently sent out a statement regarding this, saying the WHO has noted that other scientists have not been able to reproduce the results claimed by Dr. Wakefield and his team regarding the measles virus in the gut. Everything's out there. The data's out there. We just need to do a better job of, talking to our patients about this. We see a lot of these patients, talking to our neighbors about this. My wife does autism consult work for the Bellevue School District, and she's giving this talk to similar talk to a lot of the educators in that district, because there's a huge incidence of autism in the Bellevue School District and a huge incidence of patients or people coming through without immunizations. So it's really up to us to get the word out. And, I tried to be objective, but there's really no great evidence at all for the other side. So it's up to us to get this information out there.
Is there a lawsuit initiative for this? I mean, can this guy come now and be an expert witness for the plaintiffs against?
Originally it was planned for a lawsuit, but when all the data came out, it was so flimsy he couldn't get involved. And they think that's how this anti-MMR group got all these patients to agree to it. They said, we're planning a lawsuit, you get involved, we can get you in on it. But his data was so poor, they never got this off the ground.
Good.
Nick?
I'm interested in hearing from Jim about what's happening in the pediatrician's office these days.
It's a very similar story. Lots of pushback about this vaccine still, and people don't really, once they hear vaccines and autism, it's not just about the MMR, it's about vaccines. So it's even a bigger problem than just the MMR.
Which brings up Paul's talk here.
Drew, just one last question.
Yeah.
Not having been informed about this, I didn't know about the colitis connection. I thought it was just a direct thought process, vaccination, autism.
Well,
Is there a line of thought that connected these three?
Well, I'm no autism expert, I don't pretend to be, but there's a higher incidence of GI complaints in these autistic kids. They actually found in this study, in his patient group, there was a lot of constipation instead of diarrhea that had been initially allocated, but I think there's just a high concordance of GI issues in these kids, and I don't think they know specifically the reason, but especially in this study that he came out with, they didn't have any pathologic findings at all. So that's how they initially tried to frame it. There was this whole hypothesis that they could break down the gut causes some of these proteins that go to the brain and cause damage to get to that normally wouldn't. And there's been no evidence for that either.
Well, and then, I see so many of these people, what did they come to see me for?
Allergies.
Yeah, because there's gut inflammation from whatever food that they, so it's either the gluten or the dairy, and of course their skin tests are negative, right?
Right.
Right, and then, when you say to the family, if it was this easy, I would be a gazillionaire, right? If I could tell you your kid was allergic to milk and it would make their autism go away,
Line them up.
but it's not.
In my N of one with the autistic kids, and a friend of mine has an autistic daughter, there's behavioral issues too that affect what they eat and how they eat and why they don't eat this and why they don't eat that. So.
Can I just say a couple things? There's a case of a lawsuit actually from the East Coast of a child, a little girl who had developed neurologic defects after getting MMR, and that family actually won that case, and it was found that she had a very rare mitochondrial disorder that was exacerbated by the MMR. So I think that's why there's that statement where you can't say it's not going to cause anything, because who knows, the one person in a million has this rare defect that may be worsened by any vaccine. And then the thimerosal, it's in older children's flu vaccine, but none of the infant vaccines have thimerosal in them.
Yeah, and the autism, obviously no one knows specifically what causes it, but that's a whole different pathology what you're talking about. And I understand why they have to put those comments up there. But, they have to.
But that was
There was a good talk on Quad AI last year about this, where they said, you can't disprove.
It's hard to disprove the null hypothesis.
So that's why there's no scientists speak, and it's not.
And you got to protect yourself against litigation.
Lawsuits. That's why I'm being careful with what I say with this online.
We need a dictator
It's recorded.
in this country. And here he is.
We had a case in Everett, and one of the epidemiologists came into town, and he said there's really two problems that we're facing now with vaccinations. Is that the young parents today grew up without any of these diseases. So they haven't seen measles, they haven't seen chickenpox, they haven't seen people die from these things. And as a result, they've got this thought in their head that maybe these vaccines are bad, and they've never seen the diseases they're getting vaccinated against. So I got actually one of the nastiest letters in my personnel file at the Everett Clinic is from a lady who had two children with IgG subclass deficiencies and basically common variable, and she didn't want to vaccinate her kids, and she wanted me to take care of her. And they're like, I don't really think I want to do that, So she actually wrote a letter saying that I was a despicable doctor because I didn't want to take care of her children without vaccination, and it was her choice, and it wasn't my choice. So that's probably my worst letter in my personnel file. And this lady, she doesn't know what she's doing, and I think they don't realize that these are preventable diseases that are going to kill their children. And all these 30-year-old parents now who grew up without polio, without smallpox, without diphtheria, without tetanus, they're making these decisions, and that's the really frustrating part. You can't get around that. So to move right onto that, into the resurgence of pertussis because we don't vaccinate ourselves, that's the next thing. So it's funny, when I saw Drew's topic, I thought, oh, well, that's interesting. We'll go right after that. So the CDC shows that the U.S. is now experiencing the largest outbreak of pertussis since 1965. And in the pre-vaccine era, there was evidence for 157 out of 100,000 patients were reached as the incidence of the disease in the pre-vaccine era. And then states with effective immunization programs got that down to less than 1 per 100,000 in 1973. And then starting in 1973, people started not vaccinating again, and they switched to it. Another issue later is the vaccines don't work as well, but the initial breakthrough with this epidemic is that people stopped getting vaccinated as the incidence of the disease went down. And we have data that every 2 to 5 years, pertussis is still going around, and it's been doing that for the last 30 years. So even with vaccination, we still have these little minor outbreaks of pertussis. And it's in the community today, and in 1982, the incidence started to go back up, so that the epidemic in 2005 was 9 per 100,000, and then a second epidemic of 9 per 100,000, which is different than the 1 per 100,000 at the nadir of this epidemic was less than 1 in 100,000. So the most significant epidemic is the one we're having right now. So there's two separate things that you need to consider. And one is the epidemiology depends on how you identify the disease, and one is in just surveillance. And as people get more knowledgeable about the disease, the reporting starts to change. So the better their surveillance network, the better the data. And then the second is, how can you prove that you have a true Bordetella pertussis infection based on laboratory data? And there's three types of studies. So the first one was this cause of prolonged illnesses in adults and adolescents. And what they did is they did a serologic titer increase, and they found 13 to 20%, and that was the first study. The second set of data looked at just antibody titers against Bordetella pertussis in a convalescent population, and then they got 1 to 6%. And now they look at prospective studies. They're showing an incidence of 370 to 500 patients. And this is with new technology, which is basically the PCR technology and different vaccines. So most of the epidemics prior to 2000 were identified by just increased awareness with physicians. And then with the media attention to vaccine safety, which Drew just went through courtesy of the wonderful Dr. Wakefield, then the studies of the DTaP vaccine in the 1980s have shown that it's significantly less effective than the DTP that was used before that. So now we have a second problem in this, in that we have a vaccine that's not as good as the previous vaccine, and that people are becoming more aware of the disease. So it's hard to really correlate the data on epidemic status when you have a really radical change in technology and a radical change in reporting. But aside from that, it's still increasing fairly considerably. So PCR is now the standard for use in diagnosis and only requires one blood specimen. So you don't get a convalescent titer to prove it. You get a single specimen, which they think makes reporting a lot easier. And then the data that the DTaP vaccines are less potent than DTP, there's probably been 6 studies now that have shown that immunity wanes much faster with a DTaP than it does with a DPT. But unfortunately, you can't really get DPT anymore, so you're stuck with a DTaP. And you can't get the fractionated vaccines either. You can't split out the diphtheria, the tetanus, or the pertussis anymore because they're not available. So people like me who have had an arthritis reaction to tetanus vaccines can't get a DPT or a DTaP because I can't get the tetanus taken out of it. So it's just made a lot of different problems. So if you take all this data together, the failure of the vaccine and then some significant genetic changes in the organism, this makes sort of one concerned that this epidemic is not going to be as limited as the ones in the past. So there's genetic changes that have occurred in the organism over the last 50 years, and they've occurred in 3 pertussis antigens, the toxin, the pertactin, and the fimbriae. So the changes in the fimbrial agglutinogens related to the vaccines were noted about 50 years ago because they could see that when they actually cultured the organisms out and could see the differences genetically. Then there's some studies in the Netherlands and Australia that implicate genetic changes that have caused vaccine failures. But unfortunately, there's equal numbers of studies that have shown that that's not really true. So whether the genetic changes have caused the vaccine failures or not, there's not really much question that the current vaccines are not as good as the previous ones. So we've taken a giant step backwards in this preventable disease by going to a vaccine that's less effective. And then you combine that with the fact that the parents don't want to vaccinate their kids. So now we have a relative mini epidemic brewing just because of changes that have occurred in our vaccine practices from a basically totally preventable disease to one that's now a concern. So the question first is, can we get a better vaccine? And that's being addressed now by CBER at the FDA. And then the second question is, can we use the vaccine that we have in a better way? So one of the recommendations is that we vaccinate pregnant women in hopes that they'll give their children titers that will protect them for the first month or two. And then the problem after that is women with multiple pregnancies quickly, they often get in trouble with the vaccines and they can't tolerate repeated vaccine dosing because of tetanus toxoid exposure that causes pretty significant local reactions. The second is to use the vaccine that we have and use it similar to the way they used it 30 or 40 years ago and give them 3 doses by the age of 3 months. And back when this disease reached its lowest level of incidence, all 3 of the vaccines were carried out before 5 months of age. And we've sort of gotten away from that with our current vaccine recommendations. And again, the vaccine we have doesn't work as well. It doesn't give titers that are the same. And yet we've sort of slacked off in terms of really pushing the parents into this. And then with the current literature questions about whether this is causing other diseases. It's just made everything worse. So that is my vaccine question. And are we doing our patients a service by not really forcing them into thinking differently about vaccination? And I think the pertussis epidemic that we're seeing right now shows us that this is a real phenomenon. And now there's measles epidemics that are showing up. There's pertussis epidemics. And these are diseases that should be gone. And unfortunately, they're not gone. So we're doing something wrong as a country or as a profession, but we're not getting the message to the people who really need to get the message. So,
Paul, do you know why they made it acellular?
You want to repeat the question?
The question is why they made the vaccine acellular. I think that was an attempt to get rid of side effects, but I'm not sure exactly that is the reason. It didn't. It did cut down on the side effects. Unfortunately, it cut down on the results as well.
Just segregating out those that got the vaccine back in the 50s or 60s like us, are we still protected? Do we need the updated vaccine?
You know, it's interesting. They're recommending now that everybody get vaccinated.
I know they do, but I wonder if they took that into account.
I didn't actually see that specific data. I just saw the recommendations are that everybody who's around children should get vaccinated, trying to bring herd immunity back into the equation and see if we can stop these epidemics, especially
Right, 'cause
healthcare workers.
there are still adult patients that come, that you'll see in the office that have a chronic cough, and they have pertussis.
And they had the old vaccine.
They had the old, because it's all the Snohomish
I just
County
wondered
people.
I wondered if they epidemiologically
Yeah, I don't know.
segregated them and seen
Yeah,
whether
if they're better protected or not is likely to have
Anybody
it.
look at titers or anything like that to see if they're still protected or still protected?
Well, I get titers on those people sometimes.
That's what you're asking.
Yeah.
We don't know the answer.
Yeah, but we don't know what the N is.
We know the old vaccine worked a lot better, but everybody loses titers over time, so none of them give you permanent immunity. It's not like the other vaccines we have that theoretically give you.
But we went for years and years and years without seeing epidemics, and I think it was because of the old-time vaccine.
And then the fact that everybody got vaccinated.
And that helped too.
Yeah,
The
so-
vaccine wasn't as good later.
Right. So now the vaccine's worse and people are opting out. So all of a sudden we've got the makings for a new epidemic that are sort of starting.
Why do we have the highest rate in this state?
You know, that's a question that's been addressed 3 times, and they think that it's actually educated parents with the thoughts that they can read the literature themselves and they're not taking their doctor's advice.
No, not that highest rate, the highest epidemic rate right now.
Right now, the thought is because the vaccine's
The gaps are so great.
and the
Herd
number of
immunity is
people. See, since Washington has the lowest or the highest opt-out for vaccination, the epidemic pertussis is one of the highest spots in the country right now.
All right, we
Steve,
got 1 minute for this last article, which I thought was an interesting article.
Go ahead, Steve.
Well, I was just going to say, this is not medical science, but there seems to be, for some reason, upon us, a complete distrust of any recommendation from the government and some people that is in the mainstream. And it seems to me that the CDC or whoever needs to analyze how they can get back into the favor of a book club conversation, which is how this cockamamie stuff gets started in the first place when people opt out. And
It would be nice if there was some forum where they could just say, this is all bull and you really need to go back to vaccinating your children. But like you said, there's this underlying distrust.
I think it's a marketing
at the
challenge.
level of our society that people just don't trust the government in any context, whether it's vaccines or anything else.
The American Academy of Pediatrics has a campaign going to educate people, educate physicians so that they can get the word out to families and answer these questions, because patients will bring, WebMD files for you to review or books quoting that vaccines are unsafe. And if physicians don't know what that is, they can't, give them the information, the appropriate
I
information.
plan on giving him a copy of Drew's notes as soon as I get back in the office.
Get sued.
I'll take your name off so I don't have to.
Dr. Ayers' email.
Anyway,
The younger Ayers.
Lynn's question to this article, I thought this was sort of interesting with tiotropium. And basically, I thought that when the tiotropium data came out that it looked okay for COPD, but it really didn't seem to do much for asthmatics. And yet the asthmatics that we have the most trouble with, this may be a drug that can help you stay out of trouble. So the initial studies for approval showed that it worked in COPD, but not in asthma. But now people are using this in asthmatics that are on maximal medical therapy and are not controlled. And they've actually been able to show that there's a fairly significant increase in the duration to a flare of asthma in people that are on tiotropium as well as combination LABA steroids and high-dose steroids and leukotriene inhibitors all together. So they followed this data there in the first study was between 18 and 75-year-old patients with a 5-year history of asthma diagnosed before age 40 to try and take out the COPD component. And they had to score different things on their questionnaires, and they had a FEV1 of 80% or less. And after 30 minutes after either salbutamol or albuterol, despite being on high-dose steroids and equivalent long-acting beta agonists. So they did 2 studies in parallel, 48 weeks duration, for between October of 2008 and July of 2011. They had a 4-week run-in period where they screened them, and then they were randomized to either get 2 puffs of tiotropium, which is 5 micrograms, or matching placebo. And then they were able to continue their theophylline, leukotriene modifiers, anti-IgE, oral corticosteroids if they're on a low enough dose. And then it was open-labeled rescue inhalers with either salbutamol or albuterol. And then they had 2 lung function endpoints. One was peak FEV1 3 hours after administration, and the other was trough FEV1 at 24 weeks. But then the third endpoint became actually the most statistically significant, is the time before the first severe asthma exacerbation requiring a doubling of prednisone dose. And since the baseline prednisone was 5, they considered a doubling as 10, which I'm not sure I would consider that a big flare, but that's the criteria that they used. And then they got 1,335 patients that they screened, and they randomized just over 900. And it was pretty equal between 409 patients on tiotropium and 405 patients got placebo. The study characteristics were pretty much the same. It was predominantly female, 50 years old, BMI is a little bit higher than you'd like, exacerbations less than 3 per year. And then there was similar numbers on oral steroids, anti-IgE, and leukotriene modifiers. They had the serious adverse events were the same in pretty much both groups, and cardiac events were less than 2% in both groups. So then they found out that adding tiotropium once a day provided a significant statistically bronchodilation, which although it wasn't huge, it was 86 milliliters in one of the studies and 154 milliliters in the other, which sort of was not what they had hoped. But the second one was how long it took them to flare. And that was really the endpoint that was the most significant, because they could statistically change flares of asthma quite dramatically with this. So these people are already on leukotriene antagonists, theophylline, steroids, LABAs, everything anti-IgE, and yet this was able to show statistical improvement over all those other modalities to show that this was a significant event in adding tiotropium. The most common side effect was dry mouth, which you'd expect sort of from the anticholinergics. But the study conclusion was that with poorly controlled asthma, despite maximal medical therapy, that we may want to think of adding tiotropium to that group because it does provide significant clinical improvement. I'm not sure laboratory-wise anyone would jump at 100 milliliter FEV1, but it keeps these people from flaring up and it makes them clinically happier. So that was a surprise because I didn't expect I thought I looked at this and here's a negative report, but it was actually positive. So anybody had any experience with that? Steve?
Yeah, I definitely try it in difficult asthma, absolutely. I think we need to learn the genetics of who responds, but it's not everybody.
When's the Respimat going to be available for that drug?
Oh, they didn't comment on
I mean, that's what they use in this study.
Yeah.
We still have to use little.
When is Atrovent going to be $5? Hasn't it been around since we were children? It seems like.
I don't know. I have to check BigMountainDrugs.com and see if it's $5 or not. So,
because that's still really expensive.
Yeah.
Yeah.
Actually, in Canada, it's not so expensive. You can get Combivent in Canada for $12.
For how much?
$12.
Really?
Mm-hmm. And you get Ventolin in Canada for $10. So, but that's you don't need a commercial for the Canadian pharmacy system. So
we're over.
Okay.
Thank you. All right. What's next week?
It's me.
Huh? You're next week?
Oh, God.
Okay, good. All right, thank you all.
Thanks,
It was perfect.